All right, good morning. Welcome to another session of Nephrology Grand Rounds, a special session of Nephrology Grand Rounds today as we celebrate the 40th anniversary of the start of the clinical trials in EPO that were spearheaded right here in Seattle. Today we have a collaborative session that's going to include three talks led by, two of our own, here Dr. Ian DeBoer and Dr. Matt Rivara, as well as Clibber Fertrin, who joins us from the Division of Hematology and Oncology today. And so I think without further ado, I think we'll go ahead and get started with Ian.
Yeah. Thank you, Daniel. Can everybody hear me okay? I've had a little bit of a cold and I was yelling a little bit too much last night. Wow. All right. And so today, this is a theme day. The theme is anemia management, and we'll take sort of a chronologic approach. And I have the pleasure and honor starting with the first part of anemia management history, development of erythropoietin, which is really an incredible story. Starts with observations in patients, goes to the bench, and comes back to management in patients. And some of you know that I'm underqualified for this. I know very little bit about anemia or EPO management. I've done some research. The reason I'm volunteering for this is I do hold the Joseph W. Eschbach, MD, Endowed Chair in Kidney Research. That's a position that I cherish and honor, and actually was taught initially about EPO therapy and EPO trials by Joe Eschbach. When I was a fellow, we had a rotation at the Northwest Kidney Centers. It was an outpatient rotation where we learned about dialysis circuits, et cetera, and had one-on-one sessions with luminaries in the field. John Stivelman was one of those. Joe Eschbach was another. And he initially led me through these trials. And so I've really enjoyed going through them again and learning the history of how EPO came to transform care for our patients. This is a really vibrant history in Seattle, and I was not here in Seattle at the time. So happily, Mike Kelly, who's here in the front row, has agreed to co-present with me today. And I hope to sort of sketch out the key history of EPO and the trials that we've done here. And I think Mike hopefully will color it in a little bit with some more knowledge of what things were like here in the 1980s when a lot of the really exciting innovation happened. My disclosures, as far as I know, don't have anything to do with EPO. So just to take a step back to begin with, I mean, Seattle is an incredible place for nephrology and for dialysis research. Belding Scribner, of course, was really a leader of a lot of the innovation that happened in the 1960s, 70s, and 80s. And there have been a lot of advances that really have been spearheaded here in Seattle. I've listed some of them. Advances in vascular and peritoneal dialysis access, which allowed maintenance dialysis to start here at Northwest Kidney Centers. The first maintenance dialysis programs focus on home dialysis from the beginning and still today, with a lot of experts here in the audience in home dialysis. And then, of course, as dialysis got started, the big complications of kidney failure also needed to be managed. And the two biggest ones really are anemia and mineral bone disease management. And so today, of course, we're talking about anemia management. I think it'd be fun sometime to have a mineral bone disease session like this too, if we get a good opportunity. Really some great advances in that field here too. And of course, Scribner led a lot of advocacy efforts, and those led to changes in policy, including coverage of dialysis treatment by Social Security. And we have great leaders in policy and advocacy still today, and a lot of additional advances here in the field. So it just makes me remember how fortunate we are to be in a place that's the center of action for nephrology research and clinical care. So the three sessions today, I and Mike are going to talk about development of erythropoietin through 1989 when it was approved by the FDA. Then Matt and John Stivelman will talk about application of erythropoietin and anemia management to the present day. And then Clibber Fertrin is going to talk about new therapies and forward-looking, sort of a chronological approach. So I thought I'd start with a bit of a timeline and a history. And the complication of kidney failure by anemia has been recognized for almost 200 years. Also, the relationship to hypoxia has been known for almost 200 years. And that observation was made by the fact that people who live at higher altitudes have higher hematocrits, and people who move to higher altitudes over a period of weeks generate higher hematocrits over time. The reasons for this were, of course, not initially clear. And it was in 1906 that the first data were presented that there's a humoral factor that's responsible for boosting erythrocytosis. And that observation was made by Clotilde de Fondre here on the right, working with Paul Carnot in France. And she was actually quite amazing. She did seminal experiments in transplantation, so immunogenicity of skin grafts, which were quite important in that field. She worked on metabolism in the liver and fatty acid synthesis in the liver. And then she did this work identifying this humoral factor. And that was done in rabbits back in the early 20th century. And by making rabbits anemic and therefore stimulating erythropoietin production, she isolated plasma from these rabbits, injected it into normal rabbits, and saw that raised their hematocrit. So a pretty simple study. It's actually a very short report, unfortunately only in French, but I did find this English snippet here of the translation. And plasma from unphlebotomized rabbits did not have the same response. So she made the reasonable conclusion that, in fact, there's something in the plasma that's stimulating erythropoiesis. So later in the 20th century, there are a number of additional advances. There are additional experiments in animals confirming the humoral nature of erythropoiesis. The kidney was found to be the source of this by experiments that selectively removed one organ at a time, essentially from animals, and found that the response was blunted in anephric animals. And then a real step forward was in 1977 when erythropoietin was purified from human urine. And these was done from patients with aplastic anemia who have bone marrow that's not responsive. They're anemic, but they have completely normal kidney function, so they're able to mount very high levels of erythropoietin. I still haven't figured out exactly how erythropoietin gets into the urine or what it's doing there, but it was in the urine, and that allowed it to be isolated and purified. And that led then to the next steps in the 1980s, which looks to me to have been a very furious decade of advancement in this field, starting with cloning of the erythropoietin gene. That was in 1983. Very quickly then, and I have a slide on this later, recombinant erythropoietin was started to be produced by Amgen. And that same year, Eschbach and Adamson launched their first human trials. And actually the first patient was enrolled in the first trial in December of 1985. So 40 years ago to the month from this presentation here. With publication of that trial in 1987 and eventually approval of erythropoietin by the FDA in 1989. So pretty quick advancement from these bench discoveries to clinical application. And Joe Eschbach and John Adamson, shown here, really were the key figures in this advancement. And that's something we have to be very proud of here. This is a picture of the two of them from the Seattle Times in 1987. I don't know if anybody knows where this was. I'm not sure if this was a UW lab or maybe a minor in James, where Joe practiced. John, do you know? Not sure?
I don't know.
No, we don't know. It's a great photo, though.
I remember when it was a new picture.
Yeah. Yes. Yeah. Not so new right now, but thank you. And this they were really highlighted also. The American Society of Hematology, when it turned 50 years old, made a report of real advancements in the field of hematology, and this was one of the several highlighted advancements in the field. Really transformational. So before the trials, actually, Eschbach and Adamson had been working in anemia using sheep. And I love this photo of the sheep being dialyzed. They really use this model in really incredible ways to understand physiology and treatment. So why did they use sheep? Well, they actually were able to maintain vascular access for dialysis in these sheep for 6 months or more They used carotid jugular access, so it was arteriovenous dialysis. You can see in the sheep here, they've got the catheter showing going up its back and then around out of the cage and over on the left to this, I think it's a plate dialyzer over there. John's nodding for dialysis. Keel, yes, all right. Keel dialyzer, thank you.
You assemble it yourself every time.
I'm glad I wasn't a fellow at that time. So the vascular access was possible. The sheep also had a large blood volume, and as you'll see, this was they were doing studies that required frequent blood sampling, which could be done. Uniquely, sheep have different hemoglobin isoforms. So when they're really reticulocyte reticking, they actually, some of them at least, produce a different form of hemoglobin called hemoglobin C, which could be isolated separately and help to quantify erythrocytosis rate. So what was done with these sheep, they did a subtotal nephrectomy. It was a staged approach. They took out about 90% of one kidney, let that heal, and then took out another. So it's, I guess, not a 5/6 nephrectomy. It's a 9/10 nephrectomy, maybe more than that if I add up my math. That did make them uremic, and then they would dialyze them a couple of times a week. They were treated very well, as far as I can tell. Mike might be able to flesh that out a little bit more, but I hear they had salt, water, alfalfa pellets, and hay. And unlike what we do for our patients, human patients, they're actually allowed to eat on dialysis. You can see that here, this sheep eating hay while being dialyzed. And then a method that they developed and refined and used during this was something called ferrokinetics. So they could inject a very small amount of labeled tracer iron and see how that disappeared from the plasma and was incorporated into red blood cell, which is a direct measurement of red cell production that they also then translated to humans for the seminal studies. So the sheep model was actually very good as a model of anemia of uremia. And I'm going to show a few figures from a JCI paper published in 1984. And on the left here are erythropoietin levels. This is a radioimmunoassay, and the units are milliunits per mil. And this is a little bit hard to see. There are solid dots, black dots, and then white blocks dots. And the solid ones are from normal sheep, and then the open ones are from uremic sheep. And so for normal sheep, you can see that at normal hematocrits, EPO levels are quite low, so 30 to 40 milliunits per mil on this assay. But when you get below hematocrit about 20%, it really they rise exponentially. So this is a log scale on the y-axis, and you can see EPO levels go up a couple of orders of magnitude with anemia. For uremic sheep, the EPO levels were lower, and while they went up a little bit, they didn't go up nearly as much. And that, of course, is why they were anemic. So on the right here is an experiment shown with the same sheep studied twice, once with normal kidney function and once after they were a chronic kidney sheep, if that's a word, I'm not sure. And what they did here is they isolated from other sheep who were anemic but had normal kidney function erythropoietin-rich plasma, and they injected it either twice in this middle frame or repeatedly on the right side, and they tracked what happened. And shown here are plasma iron turnover, that's the ferrokinetics, which you can see increased, and down here is the reticulocyte count, which went up, and then when they stopped, went back down. And with sustained treatment, you can see there was sustained erythropoiesis with iron uptake and reticulocyte count. And you can see there are two curves here. So one is from when the sheep had normal kidney function, and one after the nephrectomy. And a big question that was answered by this study is erythropoietin replacement on its own enough to correct anemia in uremia? Anemia in uremia. I think I said that right. Or are there inhibitors? Because there were theories that there were also uremic inhibitors of erythropoiesis, and that just giving EPO wouldn't do it. But you can see by these overlapping curves that, at least in sheep, the response to erythropoietin was very similar, whether you had normal kidney function or not. And it really allayed some concerns about inhibitors. So here then also, are studies looking across multiple sheep, and you can see that this erythropoietin here in units per kilogram is what was administered in this erythropoietin-rich serum. But the more that was given, the larger the change in red blood cell mass. And here on the right, the more EPO given, the more ferrokinetically determined plasma iron turnover. And the relationship was the same with or without uremia, again, suggesting the absence of inhibitors, or not important inhibitors. So, of course, infusing erythropoietin-rich plasma, not scalable, not really translatable to humans. And what really made a huge difference then was the generation of recombinant erythropoietin. And on the right here is a figure of erythropoietin. It's 165 amino acids, I think. And 40% of its weight is actually these post-translational modifications, these glycosylations. And so it's a tricky molecule to make, and it was successfully made in Chinese hamster ovary cells, which is a common pharmaceutical approach. It's a mammalian cell, so its production and post-translational modification is similar to humans. And I believe that now the EPO forms that are out there differ largely in the post-translational modification. Epogen, the first one, was generated this way, and I think it's still generated the same way as far as I know. And then that enabled really the landmark trials. And this was the big one. This was published in the New England Journal in 1987, correction of the anemia of end-stage renal disease with recombinant human erythropoietin, results of a combined phase 1 and 2 clinical trial. This is the one that started 40 years ago to the month. It enrolled hemodialysis patients who had hematocrit less than 25%. They were not allowed to have hypertension, or they had medically controlled hypertension. They did not have other causes for anemia like hemolysis or blood loss. 25 people were enrolled, and I think characteristics of the time, many of them were on home dialysis. Many of them had received transfusions within the last 4 months, and almost half of them were transfusion dependent, so getting multiple transfusions every month. And they started with a mean hematocrit of 19%. That's what the population looked like in 1985 before EPO was around. And what they used here was essentially a single ascending dose design. That's what we would call it now, where cohorts of patients were enrolled sequentially, starting with a very low dose and then a higher dose. And you can see here, doses in units per kilogram went from 1.5 up to 500 3 times a week. And each of these were 3-week sessions. And then after the 3 weeks, people were allowed to continue if they responded. And with the first 2 doses, there was no response. I'm not sure what they were thinking at the time, but I would have been very worried at that point. They saw nothing. Ultimately, 4 of those people actually were included in the high dose group, and as you'll see, responded. When they got to the 15 units per kilogram dose, there was clear response. And this is a New England Journal clinical trial report that is unlike those that we commonly review in Journal Club these days. These are figures 1 and 2. They both report results for individual patients. But I think for first in human studies, this is really quite compelling. And so I'll go through them. So on the left is a patient who had the 15 unit per kilogram dose. These arrows are transfusions. So they were getting regular transfusions. This is time 0 when they started the EPO. And you can see the first thing is they maintained their hematocrit without needing transfusions. There's a blood loss here. I don't know what that was. Maybe vascular access disaster. Not specified. Over time, then, with sustained application of the EPO, hematocrit did get up to about 25% with moderate sustained reticulocytosis. Here's a patient who got the 150 unit per kilogram dose, also transfusion dependent, immediately required no transfusion. Hematocrit came up quite nicely with a sustained erythrocytosis. And then look at these levels of the other labs. This is a patient who starting had an iron saturation of 100% and a ferritin over 5,000. So I've never seen an iron saturation of 100%. Kleber, maybe you have. I don't know. I've only seen ferritins like this in residency with hemochromatosis, but this is from all the transfusions I think that they'd been getting, and those numbers started to improve.
These were low.
All right.
They were low.
Those were all right. So these were low. Amazing. So, the trial showed and this is using the ferrokinetics, erythropoiesis increased by 360%. Transfusions were no longer required in any of the 4 effective doses. Hematocrit was sustained at 35% or more in most of the patients at those doses. There was a dose response shown in this figure on the right that's been reproduced many, many times. Some initial side effects were observed. I don't know if functional iron deficiency is a side effect, but it was reported here. There was hypertension reported for the first time. One patient had a seizure, and there was increased creatinine and potassium, which was attributed actually to decreased effectiveness of dialysis. I'm not sure if that's still thought to be the case or not. This was clearly well regarded at the time. What I've pasted here on the left is an excerpt from the editorial in the New England Journal that accompanied it. I'll just quote, "This is a crowning achievement by 2 teams headed by investigators who for the past 25 years have made important contributions to the field." There was a team in Britain as well who was working on this and published in The Lancet about the same time. The research suggests a future in which the physical and emotional debilities of anemic hypoxia may be alleviated in patients with chronic renal disease and possibly anemia from other causes. And then the New York Times reported on this synthesized drug eases kidney ills, and another New York Times that brought this into the era of new pharmaceutical protein generation with insulin, growth hormone, and other proteins that were made in a recombinant fashion and transformative for patient lives. There was a follow-up phase 3 trial. This is published 2 years later. 333 hemodialysis patients. Initially, they all started with 300 units per kilogram and had the hematocrit response you can see here on the left, quite vigorous, and reduced to maintenance dose. And because the response was so vigorous, they reduced the starting dose to 150 units per kilogram and still had a very nice response. On the right, you can see what happened to transfusions. It was about, on average, 1.5 transfusion per month, so 6 per year for these patients before the trial, and went down to virtually nothing. So really getting rid of transfusions. This was the first trial that I found that looked at quality of life. So we talk a lot about mortality outcomes and other outcomes, but we oftentimes overlook quality of life as an outcome of EPO treatment. There are a few noted here. These were all ascertained by questionnaire. This is a before-after study. There's no active control group. So one of the questions people were asked was their activity level, and at baseline, only 20% said very or mainly active. That went up to about 35%. These middle 2 questions are ordinal responses from the same questionnaire. So very full of energy or fairly energetic was 25% at baseline, went up to 45%. Those who had low energy or no energy at all dropped from 45% to 25%. And then there was a physical limitations score, which also improved. So these were quite large changes that went along with the qualitative changes that I'll summarize on a future slide. Some of the adverse effects were noted here. Again, blood pressure and hypertension related. 18 patients in this trial also had seizures, which were noted to happen during the period of hemoglobin increase, sometimes associated with uncontrolled hypertension. This study showed a bit of a physiologic basis for the improvements in physical function. So 19 patients, again, a before-after study, were studied with cycle ergometry, which quantifies their maximum oxygen consumption. And these are individual patient data shown here. On average, there was a 17% increase in maximal oxygen uptake, along with increases in strength. One thing that the team pointed out was the axis here is percent predicted. And even with a correction of anemia, these patients were not getting up to full physical function. I'm still waiting for Brian to figure out why this is. Brian, you started that line of research, so we've got some work to do here still to figure out how to get this up to 100%. The study extended to patients without dialysis. This is another paper in the New England Journal by Joe, and the second author was Mike Kelly here in the first row. This was the first study of EPO in patients who were with CKD who were not on dialysis. The serum creatinine level of these participants ranged from 4 to 11 milligrams per deciliter. And they had 2 potential dose regimens, either subcutaneously or intravenously. Both raised the hematocrit effectively. And I'm going to read again this quote from the paper. I love it. I think it's very insightful. A subjective improvement in well-being and appetite was noted by all the patients as their hematocrits increased. All our patients continued to work or be active, even though their renal function deteriorated and they began hemodialysis therapy. An unanticipated problem was the difficulty of determining when dialysis should be initiated. Extreme fatigue, usually the determining symptom, was eliminated by the correction of the anemia. Thus, all our patients continued to feel relatively well, even when their creatinine clearance decreased to 5 mils per minute or less. Nausea and vomiting, lassitude and weakness were the symptoms associated with creatinine clearances of 4 to 5. Once hemodialysis was initiated, these patients quickly resumed their previous level of activity. So really transformed sort of the presentation of kidney failure and delayed it and into what the symptoms and timing are that we more recognize today. So based on these studies, EPO was first approved by the FDA in 1989. It's approved both for dialysis and non-dialysis populations, subsequently expanded to patients with concomitant myelosuppressive disorders and myelosuppression due to treatment of HIV. And I'm going to summarize all this work with some quotes from Joe Eschbach. So he wrote many editorials. This was a nice one that summarized a talk that he gave at a meeting. I'm not sure which meeting. He was asked to talk about the promise and facts of erythropoietin. And this is how he summarized the promises of EPO. So correcting anemia, eliminating red cell transfusions, which has a number of impacts, eliminating iron overload that we saw, decreasing HLA sensitization and therefore improving kidney transplantation, and allowing for pre-surgical autodonation of red cells. This might have been one of the first sort of situations in which that was commonly done. You can imagine that it'd be very hard for kidney failure patients with hematocrits of 19% to go into surgeries that would require blood loss. Quality of life was improved. You saw the data. Rehabilitation was improved. You saw the comments. I agree. Dialysis care was revolutionized. He did suggest that maybe underdialysis might occur, and I think that's because if people are feeling well, would they need to have a small molecule removal? It's a good idea. The facts that he described here were facts that, in fact, the application of EPO had not yet been optimized in 1994 when he was writing this, and clearly there was more work to do there. I think Matt and Kleber will talk a little bit more about that. And so anyway, that's I really enjoyed learning this history. I hope that was useful for you. I want to introduce now Mike Kelly, who many of you, but not all of you know. Mike did medical school at Creighton University, went to UC Irvine for medicine residency, came here happily for nephrology, one of many UW nephrology trained nephrologists who have done incredible things. And after 2 years in the U.S. Navy, came to establish a private practice at Minor and James, where he worked with Joe Eschbach, was there for 33 years, doing great clinical work, teaching trainees at Swedish Medical Center, and chairing the Swedish Ethics Committee for 18 years. That's a great link between nephrology and ethics that we obviously still value quite strongly. And that's actually how I first met Mike. He probably doesn't remember, but I was a hospitalist at Swedish for about 6 months, and every difficult case Mike was involved in. So it was a real pleasure getting to know him there. He also has really done a lot for Northwest Kidney Centers, including being the board of its the chair of its board of trustees. And most of you who know him might know him from his days as a clinical professor at Harborview, which was fabulous. So this is a picture of him with Joyce Jackson, who's here in the audience as well. I think probably around 2008, around the time that the KRI was founded. Mike, please come on up, and I'm done with the slides. Now you can tell how it really is, or it really was at the time. Thank you. Let me turn this off.
Surely.
Yeah.
That was a great review. Thank you very much. And thank you very much for asking me to come and talk to you. I'm going to give you the take-home points right now. I want you to know that I believe that the administration of EPO to patients with kidney failure was the greatest achievement in nephrology since Scribner invented the shunt. I don't think there's anything to compare to it. And I want to try and convince you about that, how it affected patients. The second part is I want to tell you that this never would have been accomplished, at least not here, without the wisdom, the foresight, the tenacity, and the incredible work ethic of Joe Eschbach. He basically did this by himself. And also the pleasure and privilege it was for me to be part of this at that time. Just to give you a little background, I joined Joe in private practice in 1975. In case your math isn't very good, that was 50 years ago. And in 1985, about the time things really got exciting, we were both in a very busy private practice of nephrology, not at the University of Washington, at Minor and James. We were very busy. I had close to 100 dialysis patients. Then it was different. You didn't have to see them every month. Some of them dialyzed in Alaska, and I'd saw them once or twice a year. But the important thing is that Joe did this. He just worked and worked and worked. I'd go home, play with the kids. Joe would go to the lab. He'd go dialyze the sheep. They were named after people in Wagner's opera, Brunhilde and Hildegard, and he dialyzed them 2 or 3 times a week, and beautifully shown by Ian. First time I actually understood that. I still don't know how a Chinese hamster can make evil, but I'll never know that. But Joe did this. He worked constantly. And he wasn't just my dear friend, my colleague, my mentor. He was a dad, a husband, a musician, a squash player, and a singer. And I want to tell you this one example because it tells you what kind of a Renaissance guy he really was. One year, my wife and I got to sit in his seat at the Wagner ring cycle, which is a big deal. And the reason we did is he auditioned to sing in the ring cycle and was admitted to the chorus of the ring cycle. So while my wife and I are sitting in his seat, he's up there singing with a helmet with the horns coming off, like the Vikings. I mean, he was just incredible. The other thing that was so incredible about him was once this came out in 1985, he became the most popular nephrologist in the world. And I think it's important for you to know, it wasn't just the patients in Seattle who were anemic. Every kidney patient in the world was anemic. So once the article came out and we started giving EPO to patients, Joe was in demand everywhere, all over the world. And he loved to travel. And he did. And guess who covered for his patients? He went everywhere. And he was just amazing. He would go, I can't tell you, he went to every country on Earth. The only place they didn't dialyze was Antarctica, but he went there too. But he would go, and one time, I'll never forget this, he went to Beijing and talked to hundreds of Chinese nephrologists via some kind of early Zoom-like program. But he had it all figured out about how he would come home from the airplane, come to the office and start seeing his private patients. It takes me a week to recover from going to Italy, but he had this down where he would take a halcyon or something, figure out what time it was in Seattle, go to sleep, get up and go to work. I mean, the man was incredible. And you saw that. the stuff didn't stop. He just kept working and publishing. It went on and on. So I can't tell you what an amazing guy he was. But what I really want to talk about is how this affected patients. So if you were not working before 1985, you have no idea what kidney failure did to patients. It was horrible. They were walking around with hematocrits of 10, 9, 15. They couldn't eat well. They couldn't sleep well. They couldn't exercise. They couldn't think straight. They had no libido. They couldn't go to school. They couldn't go to work. They just existed, but they didn't live. And it was very, very hard on these patients. The very first human being who got EPO was my patient. KC, we'll call him. He was a young man from Vashon Island who would come over to dialyze at the kidney center. He was just dragging. But I became a renal fellow for the second time around 1984 and 85. And my fellowship went from 1984 to 85 to about 1990. My job was to get patients signed up to get on the EPO studies, to receive EPO. And it wasn't hard to convince people to take EPO. But we did that. We got them lined up. We started injecting them with EPO. And as Ian has shown you, and I'm not going to go over all that again, the change in these patients was unbelievable. Before, you could identify every kidney patient from across the street. They had this amazing slate gray color. It wasn't anemia pale color. It was gray color, probably due to the incredible amount of iron that was in their body. I think they all had hemosiderosis. And I don't know if you appreciated the fact that once you start giving transfusions, you can't stop, because every time you give the blood, it suppresses whatever marrow production there was. So they become more dependent and need more blood. And so we were giving blood. It was a huge drain on the Puget Sound blood bank. It was a huge drain on every blood bank around the world. So this change, this EPO administration changed the lives of thousands of people all over the world. And it really is due to Joe that would happen. But my fellowship continued. We lined up patients. We did more and more studies. I haven't thought about this for at least 20 years, but I presented a program at the ASN in 1988 showing that giving EPO to people with chronic renal failure did not hasten their demise of kidney function. And then I went back with another program in 1989 showing that we could give sub-Q EPO at home safely. And many of our patients dialyzed at home. There weren't that many kidney centers. I literally had patients in Alaska, patients on Indian reservations, patients in Montana that I would see occasionally. But this made all the difference in the world. So it was an incredible time. It was a huge privilege and pleasure for me to be able to actually watch these patients change from being alive but not living to being functional, living people. There was a great article, a guy named John De Palma, a nephrologist a couple of years ahead of me, wrote this cute essay in the Kidney Journal somewhere that said, uremia ain't it anemia? Because as Ian pointed out, it seems like every symptom the patients had got better when they got EPO. And the comment was, I don't want to go on dialysis. I feel fine. Well, there is this thing called uremic pericarditis and a few other problems, but they don't care. My job always when I was working is I don't put people on dialysis till they feel terrible, because then I can make them feel better and they'll think I'm really smart and they'll do whatever I want. But if I put them on dialysis when they feel good, they don't feel any better, they can think this is a waste of my time. So it became difficult to know when to put someone on dialysis. And the other thing I learned was you can have iron deficiency even though you never menstruated and you never bled. We went from having huge iron stores, hemosiderosis in patients. And John is right, the ferritin levels were astronomical. But pretty soon after we started people on EPO, especially by 1990, the iron levels are dropping. They're too low. And EPO was expensive, iron was cheap. So we started infusing iron to patients on hemodialysis so we could reduce the EPO dose. But what an incredible trip. I mean, this was a head trip that I think will never be reproduced again. So thank you very much for listening. I'm happy to answer any questions or whatever.
Can maybe take a question or two for Mike while we get the next talk set up here. Got one back in. Questions,
Right.
Comments?
Thank you.
Save the questions for break.
Oh, I've got to tell you two more things. I forgot. So the first patient in the world to get EPO, Casey from Vashon. I didn't tell you the whole story, but I'm never going to tell you the whole story. But he was a typical.
Mike, it's being recorded.
Oh yeah.
I'm just thinking, so there. I know Joe Eschbach Jr. wants to hear everything
Okay.
you say.
So Casey was a typical young Vashon Island resident, smoking dope and causing a lot of trouble. But he couldn't do much until he got EPO. And then he went back to a lot of foolishness. There was another patient I had, a young lady, SS, we'll call her, who was a big problem for me with a lot of difficulty, multiple transfusions. And her clinic chart was like this thick. You may not know this, but we only had paper. There was nothing like a computer. Her chart was gigantic. And after she got EPO, on one of her trips to the clinic, she stole her chart and burned it. And she said, I'm a new person. I'm a new person. We're starting over. I mean, it was that impressive. And I could go on forever about stories like that. So thank you very much.
All right. Well, that's a tough act to follow. Thank you, Mike, and thank you, Ian. So thank you, Daniel, for the invitation to speak today. I was tasked with carrying on the chronological story into the 1990s and the 21st century. So that's what I'll talk about today. These are my disclosures. So this is just an outline. So I'll try to show a little bit of data showing the benefits of EPO to try to sort of encapsulate what Ian and Mike have talked about. But I'll also talk about the emerging evidence in the late 1990s and the early 2000s about some of the harms or risks associated with EPO. And then in the second half of the talk, I'll talk about the changing landscape of the use of EPO and other ESAs, the longer acting versions of EPO that were eventually created over the course of the 1990s and 2000s, and how that intersected with payment policy in the US. And as I think we'll see, those two things were intricately connected. And at the end, I'm going to introduce and invite up Dr. Stivelman, who is here in the front row, who lived through this and was really involved in this whole era to make some comments. All right. So, I won't belabor this, but I think just to echo Mike's comments that the transformation of the care of patients with kidney failure undergoing dialysis that occurred with the implementation and widespread use of EPO really cannot be overstated. Okay, so in the pre-EPO era, what is shown here was common. Okay, so this is a report from the Artificial Kidney Center of Rhode Island in 1984. At the time, this one kidney center took care of 80% of all patients on dialysis in the state of Rhode Island. There were 318 patients, and over the course of 1 year, over 50% of them were transfused at least once. And I think as is evident here, I mean, some patients had a huge amount of blood transfusions, right? Patients getting 20, 25, 30, 35 units of blood per year. So in this one dialysis center, over the course of 1 year, 1,500 units of blood were transfused. Okay. There was, at the time, a lot of consternation about this, of course, from nephrologists, not only the concerns about sensitization that we've heard about in hemosiderosis, but the growing concern of infectious agents. So AIDS became to be a big concern. And what at the time was called non-A, non-B hepatitis, what ultimately became known as hepatitis C virus, was a concern as well. So with the availability of EPO and its proliferation, there was just an incredible transformation of care. So this is from one paper looking at Medicare claims data over a 12-year period, 164,000 patients ultimately, showing that the rate of transfusion went from almost 600 per 1,000 patient years down to sort of 200 to 300 range in the late 1990s. It did take some time for this to occur. And look at another way. This is data from a 2008 USRDS annual data report that showed sort of from 1993 to 2005. Right, this is the kind of situation we were living in then. So about 80% of patients now required no transfusions. Right, and the percentage of patients requiring more than one transfusion became really vanishingly small. Only sort of 10% or less of patients. And for incident patients, you can see the progression over 1992 to 2006. The cumulative probability of transfusion went from about 30% down to only about 10 to 15%. Now, transfusions did not disappear, right? This is something that I think we should all acknowledge. So that sort of ultimate hope or promise of EPO to completely eliminate transfusions never materialized, but certainly an incredible transformation of the care of patients with anemia. And then, Ian spoke a bit about this, but the other major finding was really that quality of life and physical functioning benefit, right? So this is data from a meta-analysis from Kirsten Johansson when she was at UCSF, and this is just one sort of example of data from 5 clinical trials. Excuse me, they're not clinical trials. These were before and after studies, before EPO and after EPO, looking at physical functioning using a PRO measure called the Karnofsky Performance Status, which ranges from 0 to 100. And it's a sort of standardized tool measuring functional status among those with chronic illness that showed that on average, if you start EPO, hemoglobin and hematocrits improve and people's physical functioning substantially improves. So with these data and others that I've not shown, there was an evolution of FDA guidelines over the 1990s, where the initial target hematocrit that was approved by the FDA that was on the EPOGEN label was to target a hematocrit of 30 to 33%. This actually went up to 30 to 36% in the mid-1990s, actually reflecting the average maintenance hemoglobin and some of hematocrit in some of the early EPO trials. It was around 35%. And these recommendations, as well as the data that I've shown, influenced the first National Kidney Foundation Dialysis Outcomes Quality Initiative, DOKI, work group that suggested a hematocrit target of 33 to 36%. I believe Dr. Stivelman was involved in that group, and we'll have him comment at the end of the talk. But, I think what was little known, at least in the early 1990s, right, as the use of EPO spread, as people's hematocrits came up, was what was the association of the use of EPO and the increasingly common higher hematocrit targets with critical outcomes like mortality and cardiovascular events. So people started to look at this initially with observational studies, okay? And this is just one example. This was from Alan Collins' group at the University of Minnesota. They looked at 75,000 patients who were receiving EPO. Okay, so this was, they took out patients that were not receiving EPO. For inclusion, patients had to get EPO for at least 3 months in a 6-month period. And they looked at different hematocrit targets. So this is really achieved hematocrit. So those achieving a hematocrit of 30 to 33%, which was what they were using as their reference category, those with lower hematocrits, and those with a higher hematocrit of 33 to 36%. And even at the time, there was an understanding that clearly sicker patients had lower hematocrit values. And so there was a need to do some statistical adjustment for likely confounding variables. So data were adjusted for demographics, for comorbid disease burden, for other measures of disease severity. But despite this, what the finding was is that compared to patients with a hematocrit of 30 to 33%, those who had a lower hematocrit getting EPO had like an 80% higher risk, anywhere between a 40 and 80% higher risk of all-cause and cause-specific mortality. And those achieving a higher hematocrit target, 33 to 36%, right, had somewhere around a 10% lower risk of death. So at the end of that paper, the following quote appeared, right? Overall, these findings suggest that sustained increases in hematocrit levels are associated with improved patient survival. So this was sort of mid-1990s, late 1990s. It seemed at the time, right, is EPO for everyone? And if so, for hemoglobin or hematocrit, is higher better? Well, perhaps not. Okay, so the first major study, large study that received major attention that raised a concern that perhaps the story was not so rosy was this trial that became known as the normal hematocrit trial. People also referred to as the Bessarab study, who was the first author on the paper, published in the New England Journal of Medicine in 1998. So this was the first sizable randomized trial of EPO to examine the impact of hemoglobin targets on cardiovascular risk. Okay. So this was a study of 1,233 hemodialysis patients who had some cardiovascular risk. So they had to either have ischemic heart disease or heart failure. And they were randomized to using EPO, Erythropoietin alpha at the time, to achieve either a hematocrit of 42%, that was considered the, quote, normal hematocrit group, or a lower target of hematocrit of 30%. This chart on the left shows that they were successful, right, in achieving significant separation between the groups. Okay, so no question. You can see these are the difference in the EPO doses. So just sort of for context, right, patients in the normal hematocrit group were getting an average of about 30,000 units of EPO per week, implying that some patients were getting much more than that, right? So as all you know, sort of 30,000 units a week is sort of the maximum that we would give in this day and age. The duration of the trial was 14 months, and the primary endpoint was time to death for non-fatal MI. So the Data Safety Monitoring Board actually stopped the trial early after the third interim analysis due to a concerning trend towards increasing death in non-fatal MI in patients randomized to the, quote, normal hematocrit group. So when they ultimately analyzed the data and looked at this, the relative risk for the primary outcome in that higher hematocrit group was 1.3, so a 30% increased risk for the primary outcome. Although because the study was stopped early and enrollment was stopped early, the confidence interval crossed 1 was considered a non-significant finding. We won't delve into this, but another important point is that in the paper, it was reported that there was an increase in physical function with patients in the higher hematocrit group. So this became a topic of much controversy later on because it turns out that what was reported in the paper was not actually a comparison between the treatment groups. What was just an observation that when they pooled all the data together, that people with higher hematocrit had higher physical functioning. So we won't sort of get into that now, but that is something that often gets discussed. So although findings from this Bessarab study were concerning, they didn't blunt the overall enthusiasm for continuing to explore potential benefits of using EPO to achieve higher hemoglobin or hematocrit targets. And so, fast forward a number of years, in 2006, two independent studies very similar to each other were published simultaneously in the New England Journal of Medicine. These were both randomized controlled trials among, in this case, non-dialysis patients with CKD. So the first was the CHOIR study. This was an open label randomized trial of 1,400 patients who had an eGFR of 15 to 50. This was a US-based study, so epoetin alpha was used, which was the only agent available at the time. This was Epogen. Patients were randomized to a high hemoglobin. The target was 13.5 grams per deciliter, or so-called low hemoglobin, which was a target of 11.3. Both groups received subcutaneous Epogen weekly. And the primary outcome was time to composite of these different separate outcomes here. So death, MI, CHF, or stroke. The CREATE trial, similarly an open label randomized trial. This was really a European study where they used epoetin beta, but still a short acting agent that was also dosed subcutaneously once weekly, not available in the United States. This was a slightly smaller study, 605 patients with slightly more advanced CKD on average. And they were randomized to a target hemoglobin of 13 to 15, or to get rescue epoetin beta for a hemoglobin of less than 10.5. And then once people were started in that second group, the target was 10.5 to 11.5. Primary outcomes, sort of similar composite outcome, although in this case included more different outcomes because of the smaller size of the study. They achieved nice separation in the hemoglobins between the groups in both studies. And these are the primary results. So in CHOIR, this was a statistically significant finding. So not only was there no benefit to the higher hemoglobin target, in fact, there was a 34% increased risk of the primary composite outcome amongst those randomized to the higher hemoglobin group. This corresponded to a difference in event rate that was, clinically significant, a significant absolute difference of 17.5% versus 13.5%. The CREATE trial was smaller. And so even though there was a similar sort of signal in terms of effect size, about 30% increased risk in the higher hemoglobin group, it did not reach statistical significance. Before I discuss the next trial, contemporary with the publication of these studies was the interest from pharmaceutical companies in developing longer acting versions of EPO. So Epogen, of course, when dosed IV, really needed to be dosed 3 times a week and subcutaneously once weekly. And so there was an interest from companies, both for that reason, as well as for some complex financial and intellectual property reasons, at developing a longer acting version of EPO. So Amgen, the developer of Epogen, developed Erythropoietin, which they called Aranesp, which was a 5 amino acid substitution at a number of sites in the molecule. It allowed hyperglycosylation, which ultimately led to an extended elimination half-life. This was approved by the FDA in 2001. And then a little bit later, Roche, the European company who had developed the original epoetin beta, developed a sort of hyperpegylated polymer version of epoetin beta that led to a significant increase in the molecular weight of the molecule, an increase in its half-life, and this is what became Mircera. FDA approved it in 2007, but probably most of you know we didn't end up using it till 2014, essentially because of a prolonged lawsuit between Amgen and Roche and intellectual property concerns. So I mention this because in 2009, the largest trial yet was published on this topic, and this study used Aranesp, or Erythropoietin. So this was a double-blind, placebo-controlled randomized trial. This was the first placebo-controlled study. The others were open-label. This was, an incredible number of sites, over 600 sites, 24 countries, over 4,000 patients with, in this case, diabetes and CKD, GFR of 20 to 60. So this was just an incredibly massive effort to do this study. Patients had to be anemic, of course, with a hemoglobin of less than 11 to be enrolled. And patients were randomized to a target hemoglobin of 13 versus a strategy of placebo with rescue darbepoetin if their hemoglobin drifted down to 9. And then once they got above 9, they sort of were put back on placebo and then used again in this sort of rescue methodology. There were 2 co-primary outcomes. One was a composite of death or a cardiovascular event, and the other was a time to composite of death or ESRD. This, again, is just showing they successfully achieved separation pretty significantly between the groups. And this was the primary result. So in the composite cardiovascular endpoint, there was no difference, and same thing with the renal endpoint. But again, no benefit of the higher hemoglobin target. And what became well known from this study is a pre-specified secondary outcome was looking at all components of the composite outcomes independently, and they found a near doubling in the risk for stroke amongst those randomized to the higher hemoglobin target. So concurrent then with the publication of these trials, we also saw a change in the FDA's level of concern about these agents that ultimately was manifest in changes in the package insert and the labels. Okay, so in 2004, the FDA updated the label to reflect, quote, accumulating safety data. And then upon publication of Choir and Create, there was actually a formal black box warning that was placed on the label, emphasizing the risks of mortality, cardiovascular events with higher hemoglobin targets, and the specific guidance to use the lowest dose necessary to avoid transfusion. And then after publication of Treat, there was even stronger warning placed on in the black box. It actually removed any mention of any sort of target hemoglobin, and in fact put that specific warning about stroke on the label as well. So I'll transition now to talk about what, in some ways was even more important than the scientific data to the use of ESAs over the last sort of 30 years, which was the intersection with payment policy. And so before I get to specific ESA payment policy, just a very brief background on ESRD payment policy, because it really starts here. And the first point is that we should all understand that payment policy in the US for ESRD has focused on cost containment for nearly its entire history. Okay, so in 1972, the year before the extension of Medicare coverage to ESRD patients, there were about 16,000 patients in the US treated with maintenance dialysis. In 73, Medicare coverage was extended to individuals with ESRD independent of age. Payment at that time for dialysis was on a, quote, reasonable cost basis. It was a pure fee for service payment with a ceiling of $138 per treatment for independent facilities. By the way, adjusted for inflation, that's about $1,000 per treatment in today's dollars. And those of you who know, Medicare now pays $273 per treatment. So in 1981, because by 1980, the number of patients on dialysis had quadrupled, far outpacing everyone's expectation for what the number of patients on dialysis would be. Dialysis patients were costing Medicare by 1980 $1.2 billion a year, more than 4 times what anyone expected this would cost. So in 1981, there were major concerns, and a cost containment provision was created for the payment of dialysis, which was the first bundle. Okay, so this was created through the Omnibus Budget Reconciliation Act of 1981 that bundled all payments for the dialysis procedure, including labor and supplies, into a composite rate that was $138. By the way, that composite rate essentially stayed fixed for 30 years. And so this shows sort of inflation adjusted dollars, right? By 1989, basically Medicare was paying what essentially was $1974 for dialysis. So, this created enormous incentives for dialysis organizations to find other ways to sort of support the care. So Epogen was introduced for clinical use June 1st, 1989, and immediately became a sort of payment conundrum. So this was an incredibly effective medication, as we've heard. It was also incredibly expensive because of how it had to be created. The predecessor to CMS, called HCFAR, the Healthcare Financing Administration, set an initial reimbursement for EPO. on a fee-for-service basis of $40 for any dose up to 1,000 units. And for doses of 1,000 units or more, you got $70. So very quickly, it was realized that this wasn't working because the organizations could provide 10 units of Epogen and get paid $40, or they could provide 9,000 units and get paid the same amount. And so an OIG investigation in 1990 found the dialysis organizations made $100 million from Epogen in the first year it was available. So in 1991, reimbursement was changed to peg it to the number of units actually used. So it was $11 per 1,000 units. And not surprisingly, there was an immediate rise in EPO doses from 2,900 units as an average dose in April of 1991 up to 4,000 units just a year later. This is just a graph showing that, even though in general, hematocrit levels were not actually changing that much. And this is just, I mean, this is really remarkable, right? These figures from 2008 USRDS, okay? So this shows from 1991 to 2006, right? The mean EPO dose rose from about 6,000 units to 20,000 units over that time. And hemoglobin, mean monthly hemoglobin for dialysis patients rose from about 9.5 to 12, okay? Similarly, looking at the breakdown and distribution of hemoglobin values, you know, in 1991 and 92, you had essentially 0 patients with a hemoglobin over 12. By 2006, this was half of all dialysis patients had a hemoglobin of 12 or greater. Correspondingly, the spending for ESAs dramatically outpaced spending increases for all the rest of dialysis. So from 91 to 2004, this is a per patient per month expense, $1,000 on dialysis up to $1,100, so a 10% increase, and a 300% increase in the cost of ESAs. By 2007, the total expenditure by Medicare for ESAs was $3.9 billion. So these findings, along with the clinical trial findings, really led to a moment in 2008 where Congress said to the dialysis community, enough is enough. And put into place through the passage of the Medicare Improvement for Patients and Providers Act of 2008, an expanded bundle, what has become known as the expanded PPS or prospective payment system, that now not only was going to bundle the labor and supply costs for dialysis, but ESRD related drugs and certain what ultimately became functional categories and ESRD related labs. The initial payment was set at $229 before adjustment for various sort of wage index and comorbid conditions of patients. And then the other thing it did is it created a quality incentive program called the QIP that was really a payment penalty program that would put up to 2% of all Medicare dollars paid to dialysis units at risk based on certain quality metrics. And maybe not surprisingly, the initial quality metrics, 2 of the 3 of them were related to anemia, right? And really related to the use of ESAs. So percent of patients with the hemoglobin of less than 10 to make sure that enough ESA was used, but not too much, right? Percent of patients with hemoglobin over 12. Ultimately, the less than 10 threshold was removed in 2013, really to align with that FDA guidance that there should be no real floor. You should use the minimum amount necessary to avoid transfusion. And then in 2016, there was specifically a transfusion ratio that was inserted as a quality metric, again, to hold dialysis organizations accountable and to make sure that there weren't excessive numbers of transfusions. And really, even today, there's been broad expansion of the QIP. There remains a single anemia measure, and it's a transfusion metric. This is also a remarkable chart, right? So this shows what happened with the implementation of the expanded PPS. So in 2006, 2007, 19,000 units per week was the average use of EPO, and that just plummeted, right, to 10,000 units per week very, very soon after implementation of the expanded PPS. Similarly, hemoglobin values sort of dropped from a mean of 12 back down to, you know, around 10.5 or so, where they really have stayed since. Just another way of looking at this. So in 2007, 50% of patients had a hemoglobin of over 12. By 2015, this was 5%. of patients. So one question that occurred to me is, right, with this incredible change, did we have a resumption of large numbers of transfusions? And the answer is no. In fact, quite the opposite. The rate of transfusions, if anything, has gone down over implementation of the expanded PPS. So these are my points. So number one, again, just emphasizing Dr. Kelly's points that the impact of the introduction of ESAs on health and care of patients living with kidney failure cannot be overstated. There was early enthusiasm, however, for the potential of improvements in even things like survival and cardiovascular health with ESA use and higher hemoglobin targets, but that was replaced in the late 1990s and 2000s by growing concern about risk, I think encapsulated in these three trials, which I've discussed. And then hopefully I've shown in the last half of the talk the interrelated and bidirectional relationship between ESA utilization and payment policy in the US. So just wanted, it's really my distinct pleasure to invite someone, an expert discussant, sort of up to the stage here to provide some comments. And I think many people, if not most in the room, know Dr. Stivelman. He's Professor Emeritus in the Division of Nephrology here. He was the inaugural Chief Medical Officer for Northwest Kidney Centers, John, and I think I got the years right, 1999 to 2011. He served as the chair for ESRD Network 16 Medical Review Board for 11 years. He's been a member of numerous NKF, KDOKI work groups, and he is really an educator extraordinaire in all things related to ESRD. There's no way he remembers this, but he gave me my very first lecture on dialysis when I joined the division as a fellow 15 years ago. So, John, we're really happy to have you here, and welcome to the stage. You want to do up here?
Let's try it. Sure. If I sit down, I'll just sit down. How long? About 10 minutes. 5, 10 minutes. Okay. Yeah. I'll take it.
With this.
Yeah. I'm gonna do this with it. Thank you.
Yeah, gotcha.
Never really appreciate what new skills one can accrue in retirement. This one is impaling me here.
Do you want to scoot over here so people can see you, or are you gonna, or you want the lecture? People won't be able to see you behind there, but that's okay.
Thank you. Well, I will be brief because this is a splendid and comprehensive sort of review of the progress that's occurred in our field over a long, long period of time. I was very fortunate from the standpoint of an accident of birth to have sort of come with my training to really the middle of this period of great ferment in the ESRD world. And it was infinitely enriching. It was a thrilling time to be a doctor and to be able to spend time in places like Boston and Seattle over that period of time. Lately, let me remind you that dialysis units were, to all of you probably visiting units now, would be unrecognizable to you. Now, many folks have alluded to that, but it is true. If you walked into any unit in the early 80s, mid 80s, you would see so many problems that do not exist anymore that preoccupied both nurses, patients, and docs. The ones I think of that come to mind, obviously anemia was an everyday problem. And it made one be very attentive to the fact of which patients had total nephrectomies, which patients were waiting for transplant in an era when transfused or not transfusing was still an issue. So there was this really churning of patients, of subpopulations of which were getting enormous amounts of blood. I can remember I had once tabulated the highest ferritins I had seen in one of Boston's larger facilities, and we had patients with ferritins of 50,000, 100,000, 200,000, and nothing to do about it. There was no assay for hepatitis C until 1991. So we had no idea how we were stepping on our own toes with these kinds of therapies. You would see units in which both male and female patients received significant quantities of IM androgen therapy every month. Females too, okay? And yes, they were virilized, and you could tell it from across the room. We don't do that anymore, and it was disruptive, and it made patients' lives much less pleasant. Okay. We had patients coming on through dialysis treatments on exchange columns designed to remove aluminum. Anyone here old enough to remember the Alucard? Well, the Alucard, you could always tell who got it because the effect of the removal of the aluminum was highly exothermic. So their dialyzers got hot, and you could tell it from several stations away. We don't do that anymore, okay, as far as I can see. Other patients were on therapies for aluminum and for iron with desferoxamine, which was complicated to administer and also costly. And this occurred forever because not until EPO was used really in industrial quantities was there any ability to effectively remove iron from these patients unless you phlebotomized them and then treated them concomitantly with EPO. A brilliant paper by Mike Lazarus from probably mid-90s showed that this was completely effective therapy in unloading iron from these patients. So it was really a different kind of time. The patients looked different. They had different comorbidities. And it proved to be remarkable proving ground for people like Scribb, Chris Blagg, Don Sherrard, Henry Tenkoff, Joe Eschbach, Dr. Hickman, whose first name I've forgotten, and people like Mike Kelly. All of these people walked the earth simultaneously. And some still do. And this made this an extraordinary era to be able to be in a junior faculty position, to be training, and to be learning how fast the world changed. I'd like to finish with a one set of remarks on, I'm going to sit again, if you'll forgive me, that related to Doki, which was something I was fortunate enough to participate in, and which was run in the anemia group by Joe Eschbach. And I would enlist Mike Kelly or anyone else of approximately his and my vintage to comment on this. There was no such thing as evidence-based medicine in the basically the first initial decades of this kind of work. No one had put this together before. And it was the opportunity of seeing this astonishing evolution in end-stage renal disease care, and to discover there was virtually no literature in patients with end-stage renal disease as to what their hematocrit should be optimized at. None. It used people, normal patients, being transfused for, say, cardiac surgery or other forms of care, but there was no literature on which to start addressing these problems. So both NKF and I think other interested parties decided to endow 4 panels, beginning, I think, in between 90 and 95, that decided to actually research what the surveys of literature showed in PD adequacy, hemo adequacy, anemia management, and peritoneal dialysis. Remarkably, the literature that evolved over this period of time involved, and for the people who were going into each of these panels, there were volumes and volumes and volumes of papers, none of which had been subjected to the kind of significant analysis that they did. And one of the things I think that was most important about this looking inward and backward was the fact that, at least in this subspecialty, there was indeed a baseline of what the expectations were for appropriate evidence-based management of these particular problems, which became updated really on an ongoing and year by year review, all of which were published initially in several volumes. I was very privileged to be able to have participated in that task and look upon it as something that was enormously worthwhile, because these kinds of improvements in care, some of which are improvements in care, some of which were found not to be improvements in care, are things that only can evolve with the passage of time. And that's one of the things that made this adventure in nephrology for me to be one of the things I think that made, for me, my career to be an enormously gratifying experience and hopefully worthwhile for some patients and what we learn from it. So that's really, I'll give you one very brief story to show how different these worlds were. Every now and then, fellows early in their training in Boston were allowed to round at a place that was modestly known as the Kidney Center and was a 65 station unit on Commonwealth Avenue, used by all the nephrologists working at both the BI and the Brigham. So it was an interesting place to work. A lot of opinions, okay? And one day I was rounding, I was a first or second year fellow with the gray eminence of hemodialysis teaching at the Brigham at the time, a wonderful, incredible man named J. Michael Lazarus, who trained countless people like me in the proper way of doing dialysis. And so we believed. I was a probably 20-year-old white male that I was rounding on. And I had seen him the week before, and his hematocrit was 11 or 12. And it had been for a long time. And he seemed to tolerate this reasonably well. So I can remember rounding with Mike and telling him, listen, he's puttering along with this. He's not particularly dyspneic, but he doesn't have much reserve here of what his O2 deprivation can be. So I said, I'm going to type and cross him for 2 units of packed cells for his next treatment. And Michael scowled at me, and I will leave the expletives out, but I heard about it. And he looked at me and said, you know, this was, I can't remember whether this was an nephrectomite patient or not. He said, just give him a couple days. When he gets down to 8 or 9 hematocrit, he'll retic just fine. And his hematocrit will go up by several points. And that turned out, of course, to be the case. So I ate a lot of crow for that. My point is, that's what this was like, okay? This was not your universe. And you're very fortunate not to be practicing in that environment now, because we know much more. So those are a few sort of brief notes from history about this, and forgive me for running over.
No, you're great. Thank you so much.
Thank you, sir.
Well, thank you so much for that wonderful, wonderful talks thus far. I think, why don't we take just a 5-minute break now, and we'll set up for our last speaker. So if everyone can be back at 9:37 sharp.